Good morning everyone. Let's start with a new video, that is your shoulder instability. So shoulder instability is nothing but you have your scapulae, then comes your humerus. Imagine the humerus is not sitting with the glenoid fossa, it's going to come down anteriorly. So that is known as your instability. Any ligament which is holding up the humerus to the joint, or there is a fracture in the glenoid limb, definitely the humerus head will come out of the glenoid fossa. That is known as your shoulder instability. Now the second one will be your shoulder instability types depending on the direction. Anterior, coming the head is going to come anteriorly. Posterior, the head is going to lie posteriorly to the glenoid fossa. Inferior, the head is going to lie inferiorly. Multidirectional, that it can change the direction along with the repeated change in the direction along with the side affected, that is your muscle affected and your slap lesion. GH joint is inherently lax or loose compared to your hip joint, which is stable. Shoulder joint has high mobility compared to the stability that results of which there is high chances of shoulder joint instability, with 90% occurring anteriorly. So please remember, 90% of shoulder instability is definitely seen in anterior direction. Translation is nothing but the movement of the humerus with respect to the glenoid articular surface, in which direction the humerus head is going to move with respect to the glenoid fossa. Laxity is the amount of translation that occurs, how much it moves. Instability is not laxity, it is different. Instability is the unwanted translation of GH joint experienced by the patient. Now coming down to the next one, generally patient describes the sign as slipping. The humeral head is going to slip either in whichever direction it is going to get unstable, or giving away, or being painful, slipping or painful, giving away. Shoulder dislocation is complete loss of contact, articulation between the humeral head and the glenoid fossa. Subluxation refers to partial loss of GH joint articulation. So depending on dislocation or subluxation, the symptoms vary. Before going to instability and types, we will look into the stabilizers of the shoulder complex. Static stabilizer are your glenoid labrum and articular congruity. We know that articular congruity, the glenoid fossa is 5 degree upwardly tilted, and due to the chock block mechanism of the glenoid labrum in the glenoid fossa, peripherally it protects the head just to avoid the slippage of the head. Dynamic stabilizers are your primary rotator cuff muscle and the scapulohumeral force couples, that is your upper, lower and lower trapezius and the aid digitation of the serratus anterior. We have already seen it in the frozen shoulder video. Third point, very important point, hence strengthening of the musculature around the shoulder is the foundation of rehabilitation program for shoulder instability, because we need to focus on the primary rotator cuff, because they are going to control the rotator cuff. The rotator cuff is going to control the humeral head movement. Whenever you move the shoulder, it is going to focus the humeral head centrally within the glenoid fossa. Coming down to classification, the first one is your frequency, depending on how frequent the instability, dislocation or subluxation is seen: acute, recurrent and fixed. Second one will be your traumatic, whether the cause is due to traumatic event or traumatic due to ligament laxity. The third one is your microtrauma, congenital and your neuromuscular condition. The third main point is your which direction. We have already seen anteriorly, anterior to the glenoid fossa, posteriorly to the glenoid fossa, inferiorly to the glenoid fossa, multidirectional. The degree, the fourth main point is degree: dislocation, subluxation and microtrauma, that is transient. Now coming down to direction classification, anterior and posterior. Anterior, traumatic acute dislocation. Posterior is same traumatic acute dislocation. Now dislocation is where? Anteriorly, in anterior direction. But how do you know if both are traumatic acute dislocation, anterior and posterior? How to differentiate that? Subcoracoid, if it is lying beneath the coracoid. Subglenoid, if it is lying beneath the glenoid anteriorly. Subclavicular, lying beneath the clavicle anteriorly. And intrathoracic, within the thoracic cage anteriorly to the glenoid fossa. is your anterior. Posterior subcoracoid, beneath the coracoid process but posterior to the fossa. Subglenoid, beneath the glenoid fossa, posterior to the fossa. Subspinous, beneath the spinous process but posterior to the glenoid fossa. Traumatic acute subluxation, the cause can be for anterior instability, and same thing, traumatic acute subluxation for the posterior as well. Recurrency, recurrent anterior instability due to chronic recurrent anterior dislocation, chronic recurrent anterior subluxation. In recurrency of posterior instability, the recurrent posterior dislocation and recurrent posterior subluxation is the cause. Here in anterior, it is main thing is chronic, but in posterior, chronicity is missing. Anteriorly, fixed or locked anterior dislocation is prominent, whereas in posterior, it is voluntary, that is a traumatic subluxation dislocation, positional type and muscular type. It is not voluntary, it is not fixed. In chronic posterior, it can be fixed or locked dislocation, but due to size of reversed Hill-Sachs lesion. It is not normal Hill-Sachs lesion, it is due to reversed Hill-Sachs lesion. The grades are lesser than 25 to 25% of articular surface, 25 to 40, and grade lesser than 40. Coming down to the multidirectional shoulder instability. There are 4 types, 1, 2, 3 and 4. The first one is global instability. The first multidirection is global instability. A traumatic multidirectional instability. It is not traumatic, it is a traumatic multidirectional instability. Type 2, it is antero-inferior. Type 3, it is posterior-inferior. Type 4, it is antero-posterior. So type 1 is global. Type 2 is antero-inferior. Type 3 is posterior-inferior. Type 4 is antero-posterior. Now coming down to the anterior shoulder instability. We'll just look at this slide. We'll do the next part in the next video. Anterior shoulder instability is most common type, usually seen in 90%, usually caused by traumatic dislocation or repetitive microtrauma resulting in the symptomatic episodes of the subluxation. Usually post dislocation, after the humeral head gets dislocated in the anterior direction, the arm position is abduction and external rotation. Now why the patient maintains in abducted and external rotated? Internal rotation is going to impinge the rotator cuff, which is going to pass beneath the subacromial space. Already the shoulder joint is anteriorly unstable. Once you're going to rotate, the humeral head is going to move anteriorly. It is going to rotate, roll in anterior direction. Definitely high chances of subluxation or dislocation. Hence the patient maintains in external rotation. Adduction. Once you adduct it, no doubt the humeral head is going to roll upward, but due to the compression of the rotator cuff, which is going to pass beneath the subacromial space, within the subacromial space, is getting impinged more. Thus the patient maintains the arm in the abduction and external rotation position. Thank you. We'll meet you all in the next video.